Good morning. Welcome back to Advanced Life Support course. Let's talk about algorithm. This is the most important but the most difficult lecture that you got to understand. Upon the completion of this session, you will be able to list the 4 arrhythmias leading to the cardiac arrest, state the statement algorithms for ventricular fibrillation, pulses VT, pulses electrical activity PA, and asystole, and understand the principles of management of tachy and bradyarrhythmia. A lot of participants very scared of mega code because during the mega code, you'll be given a case scenario. But don't worry, because what you can get is only a collapsed patient, whether they have cardiac output or they have no cardiac output. So those presented without the cardiac output, only 4 algorithms: ventricular fibrillation, pulses ventricular tachycardia, pulses electrical activity, or asystole. And those with the cardiac output is either the heart beating too fast, which is tachyarrhythmia, or the heart beating too slow, bradyarrhythmia. So this is what we mentioned. And among these 4 algorithms with no cardiac output, only 2 are shockable. And that is ventricular fibrillation and pulses VT. Now, let's look at this algorithm when you got a case shockable rhythm, VF or pulses VT. For example, I give you a case of 60-year-old guy, diabetic, collapsed in the orthopedic ward. The nurse will run to you and say, "Doctor, suddenly this patient found unconscious in bed. So what should you do?" You just have to remember, you got to practice DRSADC, which means danger, responsiveness, shout for help, airway opening, breathing, chest compression. So when you got a case like this, first of all, remember the principle of resuscitation is also to take care of yourself. So you must make sure there's no danger. But in hospital cardiac arrest, unless the patient collapses in the toilet, you don't bring your resusc trolley in the toilet. So once that, you have to assess responsiveness. And what you should do is tapping the patient's shoulder and say, "Hello, hello, are you okay?" If the instructor tells you no response, then you should shout for help, saying, "Patient collapse, bring resusc trolley and defib machine." Then you proceed to open airway by head till chin lift and look for breathing. If there's no breathing or agonal breathing, then you should start chest compression. You will have some helpers around and you should ask one of the helpers to set the IV access and prepare adrenaline 1 milligram. Besides that, you should perform or ask your helpers to perform high quality CPR, which means push fast, push hard. That at least 5 to 6 cm and rate 100 to 100 per minute. Minimize the interruption of chest compression and allow complete chest recoil. Do not hyperventilate, and compression ventilation rate without advanced airway insertion is 30 to 2. With that, normally instructor will tell you your machine is here. Attach the lead and assess the rhythm. If the rhythm shows ventricular fibrillation or VT, and knowing that at the moment you are doing the CPR, then this is a case of pulses VT, then you say the rhythm shows VF or VT, therefore I need to defibrillate or shock the patient. We will have a session to show you how to handle electrical therapy, so don't worry about that. Once attached the gel pack, select energy joule to 200, then you should take a paddle, put on the patient's chest and charge and say clear and defibrillate, shock the patient. Immediately after shock, you should just say resume CPR. So this is actually the first shock. And normally we will do 2 minutes of chest compression and assess the rhythm again. Once you assess the rhythm is still VF, then you apply the second shock and say resume CPR. Immediately when you say resume CPR, and this is after second shock, you should ask a helper to give adrenaline. Instruction of giving adrenaline have to be clear. You should say rapid bolus adrenaline 1 milligram followed by saline and elevate the hand, because normally we give the drug through peripheral line. And the helper, once given the drug, should just say drug given, and this is closed loop communication. Then continue CPR, and during the second CPR, you should actually tell people to intubate the patient. Once intubated the patient, the team leader should confirm the placement of ED tube, means advanced airway is inserted, then the compression ventilation, no more cyclical CPR. You should say compressor have to compress 100 to 120 per minute, and those taking care of ventilation should back 10 per minute. After 2 minutes is the third time you assess the rhythm, and if the rhythm is still show VF, then you should give an instruction, give the third shot. After the third shot, resume the CPR, and immediately ask the participants to give the IV amiodarone 300 milligram bolus. All right, so these are the things that mentioned in the algorithm. And so on. If still no return of spontaneous circulation, then you should continue with checking the rhythm every 2 minutes. If after that is still no return of spontaneous circulation, then after the third shot, we can give 1 milligram adrenaline, and subsequently you can repeat and 150 milligram of amiodarone and so on. Along the way, if there's any return of spontaneous circulation, there's any change of rhythm on the monitor, you should stop chest compression, check pulse. Pulse present, check the BP. BP low, start inotrope and continue ventilation 10 per minute and start immediately post cardiac arrest protocol. So this is the normal algorithm for those shockable rhythm. What happened to those non-shockable rhythm but patient with no cardiac output? For example, PEA or asystole. Just to bear in mind that this is the algorithm non-shockable, so do not apply defibrillation. Same thing, when you give you a case, a patient collapse and you have to attend immediately, then do DRS ABC. Hello, are you okay? No response, call for help. Call for machine, defibrillator, and resuscitate. Open airway by head, tail, chin lift, look for breathing. If no breathing, start chest compression. And somebody will take care of ventilation. When you start, that will be 30 to 2. 30 compression, 2 ventilation. And this is cyclical CPR. Get your helper to set the IV line and prepare adrenaline 1 milligram. Machine here, attach the lead, and if let's say there's asystole or it looks some other rhythm, but you remember you are doing CPR, that means this is a case of PEA, then the algorithm will only go for drugs, adrenaline, 1 milligram, repeat every 3 to 5 minutes. Then get ready for intubation, intubate the patient, and change, once the placement is confirmed, change your ventilation compression, no more cyclical CPR, compressor 100 to 120 per minute, ventilation 10 per minute. And along the way, you must look for reversible causes. For example, 5H and 5T. 5H will go for hydrogen ion, which is severe acidosis, hypoxia, hypothermia, which may not be possible in Malaysia, and hypovolemia due to massive bleeding, hypo and hyperkalemia. And 5T goes for cardiac tamponade, tension pneumothorax, thrombosis, toxin, and trauma. So that goes your algorithm without a cardiac output. And this is overall algorithm for both shockable or non-shockable rhythm. But I would like to highlight a little bit here, because this era of COVID-19 pandemic, there will be a little bit of change that you have to bear in mind. Number one, there's something called DNA CPR, which goes for do not attempt cardiopulmonary resuscitation. Because in hospital cardiac arrest, the patient normally do not sudden collapse. There will be period of deterioration. So there will be time for clinician to make a decision whether this patient you want to go active or you do not attempt CPR. And this decision have to be made early. So if decided DNA CPR, then you live with the end of life care. If no, before you attempt to the patient, please don full PPE. And this I mentioned in the introductory lecture earlier. Full PPE, at least N95 mask, glove, goggles or face shield and apron. Start CPR, and in fact, people may consider passive oxygenation. For example, if this patient is already on face mask, you may just do a chest compression and early intubation. Remember just how I mentioned to you, intubation normally done at the second period of CPR after 2 shock. But in this era of COVID-19 pandemic, prioritize intubation, preferably after the first shock, if you can get things ready. Another important thing or big change in the intubation during this resuscitation during the COVID-19 pandemic is you got to pause the chest compression during intubation. And you have to actually, all the back valve mask or even the supraglottic airway or ET tube must be hooked on to viral filter in order to protect yourself. I would like to highlight a little bit of information about electrical therapy, especially defibrillation. One should understand the rationale of actually defibrillation. When the heart has gone into arrhythmia and chaotic movement, this cannot generate adequate cardiac output. How to stop it? You got to do something to stun the heart. The principle is actually stun the heart. How to stun the heart means that you have to use electrical energy therapy to stun the heart. And whether this heart will start back the normal pacemaker rhythm depends on how long the period of no cardiac output it is. So therefore, the rationale of defibrillation is after every single shock, you must immediately follow by CPR, because CPR will send some perfusion to the SA node to make it viable. So single shock technique, and we use fixed energy jaw. Studies have shown that escalating energy jaw may has a better reversion or outcome. However, in long term, whether a fixed energy jaw or escalating energy jaw has no difference in long-term survival. So therefore, the current ILCOR systemic review still recommend the fixed energy jaw for defibrillation. Defibrillators using biphasic waveform are preferred than monophasic, and pre-shock pause should be less than 5 seconds. Pre-shock pause means the time you diagnose shockable rhythm until the time you can apply the defibrillation to the patient. Defib machine with self-adhesive pads should be used if available. There's another term that you probably need to understand is recurrent VF or refibrillation. People have been asking, if let's say this patient has a VF at 10 a.m. in the morning, at 12 noon, this patient has another VF. Does it mean recurrent VF? And this is not recurrent VF. Recurrent VF is defined as recurrence of VF during the documented cardiac arrest period occurring after initial termination of VF while the patient remains under the care of the same provider. Means this is the same resuscitation setting. So if this is a case of recurrent VF, higher subsequent energy level is more beneficial. Means that if you use 200 for biphasic and the patient develop recurrent VF, the next shock you may have to use 270, the next higher energy jaw on your defib machine. How about witness monitored VF or pulses VT? In case, and this normally happens in the cath lab, when the patient already has the attached cell adhesive packs with the biphasic diffuse machine on the body, and suddenly this patient developed VF or pulses VT. Therefore, ILCO recommended the 3-stack shock may be beneficial because they found out that the further CPR may not offer extra help to the patient. But this kind of situation is not common. So when to terminate the CPR resuscitation? There will be actually a difference if this patient initial diagnosed collapse rhythm is VF or initial recognized collapse rhythm is asystole. Because if this is a VF, no matter how long or so-called 1 or 2 hours of VF, nobody can terminate the resuscitation because VF is always a reversible condition. If you have a resuscitation and patient persistently have a VF for 1 hour, 2 things you can tell yourself. Number 1, your CPR is very good. So you can continuously supply the VF heart with the oxygen and nutrient to maintain the VF. But number 2, you have to understand that you're probably not good enough because you haven't found out the underlying cause for VF. And how long can this VF last? It may not be too long because the heart won't be so good when they use up the oxygen and nutrient from the residual supply. The heart will go into asystole. So when this is VF, when to stop? Normally, I tell the participants, the answer is you do until you collapse or patient collapse. But what happens if the initial collapse rhythm is asystole? Asystole is a very end point of the cardiac arrest. So it's recommended in the ALS textbook by the ILCO that if there is a first recognized rhythm is asystole and the whole team is well ALS trained, you can call it off after 20 to 25 minutes. Now we talk about collapsed patient with cardiac output, whether this is bradyarrhythmia or this is tachyarrhythmia. If you get a patient that can talk, so no hurry, there are 4 things that you probably have to tell yourself to do because this will help you to calm you down in the crisis situation. Number 1, introduce yourself and reassurance to your patient. Number 2, put the patient on oxygen, put the patient on monitor, and get the IV line. Once you've done these 4, you probably have some clue whether this patient's heart is beating too fast or is beating too slow. Then you decide, next thing, is this patient stable? Whether the patient hemodynamic instability or not, you can actually look at few things. Number 1, whether patient has altered sensorium, drowsy or not, because it means perfusion to the brain is not good. Patient's BP, normally for adult cutoff point is 90, but I warn you, if you have a hypertensive patient, 70-year-old, 110 may be too low for this patient. Whether the patient has a chest pain, go into acute pulmonary edema, all this will signify that this patient is not stable. So whenever there is a symptomatic bradycardia, the treatment is atropine, 0.5 milligram to repeat every 3 to 5 minutes until maximum 3 milligram. If you are dealing with high degree heart block, for example, 2nd degree heart block, type 2 or 3rd degree heart block, normally this type of heart block would not respond to solely atropine. So it means that you have to call cardiologist for immediate transvenous pacing. So meanwhile, in order to maintain the hemodynamic stability, you got to start patient on adrenaline infusion or dopamine infusion. What happens if patient got tachyarrhythmia? So same thing, do the 4 things I mentioned earlier, reassure, oxygen, IV line, monitor. Then decide how stable is this patient. If the patient is not stable, then you should do cardioversion. If the patient is stable, then it depends on which type of tachyarrhythmia, whether it originates from supraventricular or ventricle, then can consider carotid massage for SVT, Valsalva maneuver, or IV medication. This slide is important, and NCOT follows strictly ERC guidelines. It's just because it's easier to remember. Only three level of electrical therapy or energy joule you need to memorize. Either 70, 120, or 150. If you think the tachyarrhythmia originate from the atrium, and atrium has a smaller muscle bulk compared to ventricle, so you will do 70 to 120 cardioversion. If you think the arrhythmia or tachyarrhythmia originate from ventricle is thick, so therefore you need more energy joule to stun the heart. So you use 120 to 150. So at narrow complex SVT atrial flutter is 70 to 120 for biphasic. And if this is a broad complex tachycardia, for example, VT, then you do 120 to 150. But what happened to atrial fibrillation? Atrial fibrillation, because it's abnormal multi-foci abnormal pacemaker. So therefore, the energy joule has to be big. So you use same energy joule like ventricular tachycardia. So it's 120 to 150. So with that, I end this lecture. Thank you.